All right, so today I've been tasked with talking about Group 3 pulmonary hypertension. Kind of a big topic, so we're going to cover as much as we can here. To start, in terms of research support, Henry Ford does receive financial support in the form of research grants from Actelion, Bayer, UT, and Gilead. We will be talking briefly about one of those studies involved with Group 3 PH. So today the objectives are to talk about the various lung disease states that cause hypoxemia and ultimately lead to pulmonary hypertension. We'll talk about the therapeutic trials that do involve Group 3 disease and mostly about the pitfalls of studying these patients. We'll talk about the available diagnostics that we have, including exercise testing, to help find Group 3 patients that may benefit from therapy. This is a slide that everyone's seen. This is from the 2013 NICE classification of pH. We're going to focus mostly on Group 3 disease here. Any lung disease that causes hypoxemia and leading to pulmonary hypertension. So we're going to spend a bulk of the time talking about COPD and ILD. We're also going to cover hypoventilation and combined pulmonary fibrosis and emphysema. Just to talk really quickly about the epidemiology of PH as a whole. This is a recent study from 2007. This is looking at echo data from an Australian community, 160,000 people. 4,500 of these people had echoes with a PA systolic pressure greater than 40. If we look at kind of as a whole, not surprising that left heart disease is the majority, but 10% of these people, or close to 10%, did have PH due to lung disease. We'll start off really briefly and talk about obstructive sleep apnea leading to PH. So we know that obstructive sleep apnea is incredibly common in our society. We know right now that about 3 to 7% of adult men and 2 to 5% of adult women suffer from this condition. It's marked by apnea and hypopnea events that occur over long periods of time and every night. PA pressures are affected by multiple facets of this condition, including hypoxemia during apneic events, possible hypercapnia, massive intrathoracic pressure swings, and the sympathetic activation of continuously waking up overnight. So we know that apneic events can last anywhere from 10 seconds to 2 minutes. The longer apneas will have worsening hypoxemia. Patients can draw in against a closed upper airway about negative 60 centimeters of water of pleural pressure. And we've seen in early studies of patients with very severe obstructive sleep apnea syndrome that systolic PA pressures can reach up to 100 millimeters of mercury by the end of the apneic event. Well, there's more facets than that. So we talked about increased sympathetic drive, hypoxia, and pleural pressure swings leading to pulmonary vasoconstriction, but there's also mechanical effects due to the left side of the heart, over time, oxidative stress and inflammation, and some other factors, including genetics, that all lead to pulmonary vascular remodeling in this condition. We know that that leads to RV failure. It's hard to find exactly how many patients are affected by obstructive sleep apnea because you have to look for them. And depending on the definition that you use and the modality that you use, you're going to come up with somewhat different numbers. So multiple studies are out there trying to quantify the prevalence of awake PH and obstructive sleep apnea. Again, it's kind of hard to find. You have to look at perhaps all patients and not just patients referred for echo or right heart cath, and then you have to use the right definition. So, big variety. What we do have is an Australian study that shows a high prevalence of awake PH in about 42% of patients with a mean BMI greater than 37. There's also a European study out there that showed up to 70%. But when those patients were later investigated, about half of them had left heart disease. The largest study that we have is in 220 patients, all of these people with severe sleep apnea with a AHI greater than 20 who all have right heart cath data. About 17% of them were found to have daytime PH if you were to define mean PA pressures greater than 20. But if you filter that down to people that have a mean PA pressure greater than 25 and a wedge less than 15, you go down to about 7%. But in a disease like this, it's relatively common, it's out there. And we know that all the comorbid states that come along with obstructive sleep apnea can only amplify the prevalence of PH in these people. In terms of treatment for it, we know that CPAP, surgeries, or trach can relieve the obstruction and improve nocturnal hypoxemia, hopefully improving pressure swings and sympathetic activation of arousals also. So looking at treatment, we do have a few studies out there. This particular study was able to show an improvement in PA pressures after about 4 months of CPAP therapy. And when you look at the mean PA pressure measured in the first study, this is the original study, this one was actually by right heart cath data. This is all comers, again, with an AHI greater than 20. Your average or mean PA pressure dropped from 16 down to 13. This study was repeated with a lot more patients, but again using echocardiograph data, and still a significant decrease from a systolic pressure of almost 29 down to 24. Again, we know that CPAP therapy does improve all the comorbid states that may lead to PH also. Take it a step further and looking at PH with alveolar hypoventilation, if we look at our patients with OHS and kyphoscoliosis, these patients are known to go into RV failure in many cases without the use of non-invasive ventilation. And the studies that we have that are kind of similar to what I just showed you, we know that awake pH can occur in about half of patients with OHS. So again, when we look at it that way, we talk about comorbid states, but we have to look at obstructive sleep apnea in PAH also and trying to figure out what's driving what. When we look at obstructive sleep apnea itself in PAH patients, it was present in the REVEAL registry in 1 in 5 patients. If you look at the functional class that they present at, the sleep apnea patients do present with somewhat of a worse functional class. Their 6-minute walk distance is somewhat low, however, it was not found to impact survival. I want to talk about pH and high altitude. I want to cover this one kind of quick, but there is kind of a high incidence of board questions on this and a high prevalence of Peruvians in the hospital, so I think we should cover it. If you look at the alveolar gas equation, it's not hard to figure out why high altitude can affect your oxygen. So low barometric pressure, of course, decreases PaO2. Ascension from sea level to a high altitude can show signs of altitude sickness both acutely and chronically, and over time pH that develops can lead to RV failure. The initial studies were done back in the 60s, right after the Swan-Ganz catheter was patented, and they were done in 2 cities in Peru, looking at right heart cath data in healthy Highlanders without any sort of lung disease, non-smokers, no occupational exposures, any of that. The 2 cities existed in an elevation of 4,500 meters and 4,300 meters. And in kind of pairing this data with future studies on other cities, it appears that pH does show itself at about 3,500 meters. Even before that, we knew that polycythemia developed and appears pretty proportional to altitude itself. So what you're looking at the top chart here is just various city altitudes, and then kind of comparing it with the healthy Highlanders' mean PA pressures. This actually correlates out pretty nicely if you look at 3,500 meters, where our Peruvian cities were at, also cities in Bolivia, and even Leadville, Colorado, kind of takes us right up to that mean PA pressure of 25. The bottom graph kind of correlates the O2 saturation with altitude of the same cities, and again is kind of inversely proportional to that, and also with hematocrit, although I didn't show that one. We have more studies on this, and again comparing children to teenagers to adults. Looking at the 2 that are circled there, you're looking at high altitude adults 18 to 33 and sea level adults, and you can see massive differences in their hemodynamics and hemoglobin and hematocrit.
Right.
Yes?
Are these patients that have high altitude pulmonary edema?
No.
Or even if they don't have that, they have?
No high altitude pulmonary edema, because we're comparing healthy Highlanders that have been there, that are native to that area.
So you're saying that an average patient who lives at altitude meets diagnostic criteria for pulmonary hypertension?
Yes. Yep. Yeah, I mean, even in looking at them a little bit further, these people are walking around, these are the healthy ones, walking around with a hematocrit of 60, walking around with a hemoglobin of 20 in males, that have a PVR of 330. And again, the mean PA pressure was 28.
This is what altitude?
3,500 meters is kind of the big cutoff, yeah.
What's that feet?
I'd have to calculate that one for you.
Okay.
Only Leadville, Colorado is the populated area in the United States that's that high. In terms of chronic mountain sickness, this can occur in long-term residents of high altitude, living more than 2,500 meters. These people show a hemoglobin greater than 19 in females, 21 in males. They're severely hypoxemic, more so than what I showed you in the healthy Highlanders. And these people definitely develop PH leading to right heart failure. Again, you can see sleep disturbances, headaches, dizziness, fatigue, paresthesias, and obviously they're blue. It's prevented in terms of any sort of secondary cause that might modify this. You have to look for smoking, pollution, occupational exposure would be part of the treatment. For boards, descending to lower altitude is a standard of care. Nothing else helps. Phlebotomy can be palliative. And then in terms of, for boards to prevent acute mountain sickness, acetazolamide is your ventilatory stimulant. Calcium channel blockers do help prevent high altitude pulmonary edema. And there are studies going on about the role in sildenafil. But again, chronic mountain sickness can be viewed as a maladaptive pattern to hypoxemia as opposed to our healthy Highlanders. I want to spend the bulk of our time here talking about PH and COPD. And we're kind of correlate these with some of the examples of patients that come into our clinics that don't exactly read like textbooks. So the first patient that I wanted to talk about was a 61-year-old female. She was a former smoker. She quit several years ago, but smoked up to a pack and a half a day for 40 years. She is COPD HOMO2 dependent on 4 liters around the clock. She'd previously been worked up for transplant at a major university center for her worsening O2 needs and was declined due to an NK cell lymphocytosis. She gets transferred here from a different outside hospital for acute right heart failure. In terms of what we knew about her, shortly after she was diuresed, we did have a PFT. Her spiral showed severe obstruction, a possible concurrent restriction, and moderate approaching severe diffusion impairment also. Her chest X-ray on arrival was hyperinflated. And we did have some CT images. You can see her large pulmonary artery there, and some emphysema scattered around. I hope that shows up. Her VQ test was low probability for chronic thromboembolism. Her echo was notable for high right-sided pressures. She had a very flat septum. I'm sorry, her RV and right atrium were dilated. PA pressure was calculated at 75. She had a very low fractional area change of her RV and a very low TAPSE. She also had a positive bubble study with a moderate right to left shunt through a PFO. She did undergo right heart cath, and what we found is a right atrial pressure of 13, a mean PA pressure of 56 with a wedge of 6. She had a very poor cardiac index, and her PVR was greater than 20 Wood units. So put all together, you have a patient who doesn't exactly read like the textbook, and you wonder what you're going to do with her, and so did we. But talking about PH with COPD, I'm glad that worked. I'm amazed I got that to work. Yeah. Talking about PH with COPD, we know that COPD destroys the airways and lung parenchyma, but also has really important effects on the pulmonary vasculature. What we know is that PH may be present in about half of patients with advanced COPD, but again, depends on the population of people we're looking at. Were these people just evaluated for transplant? Kind of affects things a little bit. And the question is, do pulmonary vasodilators work? We know that vascular remodeling occurs similar to PAH, and there are small trials of vasodilators, but they haven't shown a clear benefit yet. In terms of what we have on the epidemiology of this set of conditions, it's somewhat difficult. There's a selection bias. We're looking at patients who were referred for lung transplant or lung volume reduction surgery, and PH has been found in anywhere from half to about 91% of patients. More recently, we've looked at right heart cath data available for patients and stratified them by gold stage, back when we had spirometry gold stages. But again, you have to ask the question why they were cath in the first place. But what we found is that people that were in the previous gold stage 2, based on moderate spirometry impairment, PH was prevalent about 5%. Goes all the way up to 53%. What we know about the PH and COPD is that most cases are of mild to moderate severity. Mean PA pressures are generally below 35. In the largest study that we have, this looks at almost 1,000 patients. Again, COPD patients that that have severe obstruction that underwent right heart cath, only 27 of them, about 2.7%, had mean PA pressures greater than 40. If you rule out the people that had left heart disease concomitant, that takes us down to about 1.1% of people. But when you look at this very small group of people, they fit into a unique phenotype. Their airway obstruction really isn't as bad as you would expect. It's about 50% predicted. They had severe hypoxemia. They had actually relative hypocapnia and very low DLCO. Looking at it another way, this is all 998 patients stratified out by their mean PA pressures. And again, to compare, the first line on the left denotes everyone less than a mean PA pressure of 25. You can see the majority of these people do not fit in to the PH group. In terms of mild to moderate severity of the PA pressures, again, a lot more fit in, and then just the people on the right side are greater than 35. This is another way of looking at that 1% of patients that I told you about. Again, they have less airflow obstruction. Their diffusion is worse. Their oxygenation is worse. And they do have this relative hypocapnia. Not surprisingly, these 1% of patients have worse mortality. The chart on the top does show that survival in months based on the dashed line, which is going to be your patients with a mean PA pressure greater than 40 and without the concomitant left heart disease, compared with the solid line of patients who didn't. We have other markers to look at this. They all correlate: EKG, echo evidence of RV function, hypertrophy, right atrial overload, CT findings, including a PA that's larger than the aorta or the trunk, all predict more frequent use of healthcare in COPD. Looking at from a few more studies, again involving lung transplant patients, we're looking at 199 patients with PH, 200 without, that were evaluated for lung transplant. That's the survival curve on the left there. And again, you can see there's a major difference, even at a few years out, between the people of normal PA pressures and pulmonary hypertension. If you stratify out the patients with the most severe pulmonary hypertension, again, a big difference. So COPD has multiple effects on the vasculature, and intimal hyperplasia seems to be the earliest sort of form of this. This starts to occur as the natural history of COPD takes place and parenchymal capillary bed vessels are decreased. So what we begin to see is proliferation of smooth muscle cells. That's what you can see there with actin staining. As this progresses, these smooth muscle bundles start to coalesce and organize. And what you can see here is staining for collagen and elastin. And finally, by the end of this, you start to see the typical plexiform lesion from PAH develop. But the increase in PVR seems to be due to more than just pulmonary capillary ablation. We know that COPD is an inflammatory state. Staining for activated CD8 cells is shown here. And you can see increased upregulation based on staining for endothelial nitric oxide synthase and endothelin-1 in the two pictures there. All of this begins to get upregulated in COPD as it progresses along. Lastly, you see increased expression of vascular endothelial growth factor. All these different inflammatory events have seemed to have been correlated to cigarette smoking. So another way of looking at it is that cigarette smoke exposure does lead to inflammation and COPD, which cause vascular remodeling and ultimately pulmonary hypertension. In terms of the natural history of COPD, like we talked about, mean PA pressures generally don't reach high severity, and you're seeing greater than 35 millimeters per mercury in a vast minority of these patients after you take out contributing factors like left heart disease. Pulmonary hypertension does progress slowly in these patients, usually by about 0.6 millimeters of mercury per year in the mean PA pressure, and that gives some time for the RV to adapt to this afterload. In pure COPD-related PH, again, the 1%, we talked about the unique phenotype that exists. Those patients, again, have moderate airflow limitation with hypoxemia, possibly normo or hypocapnia, sorry, that's an error there, and very low DLCO. At the last conference in Nice, there was new definition kind of coming about from overuse of the term out of proportion sorts of disease states. When PA pressures are elevated out of proportion to either airflow limitation or fibrosis on CT for ILD, and we came up with the terms COPD or diffuse parenchymal lung disease without pH. Obviously, in the majority of people here with COPD with mean PA pressures less than 25, with pH is greater than 25. And we have to think about PA pressures being increased may not be proportional to their disease state. If they're in end-stage heart failure, they may have a lower mean PA pressure. And then our group with the most severe pH, greater than 35, or a cardiac index less than 2, these patients have severe pH. They do not have pH out of proportion to their COPD. Again, this is a very minor subpopulation. In terms of the diagnosis of this small group of people, we know that underlying emphysema gives us several challenges in terms of identifying pH itself or pump failure itself. Chest X-ray doesn't have the best sensitivity to rule out pH, only about 38%. EKG, again, because of lung hyperinflation, can show low sensitivity for hypertrophy, about 51%, although it is a rather specific marker. There's no specific PFT pattern that we can pick out because, as we talked about, it seems like the patients with the worst pH exhibit their own phenotype. And BNP levels can be confounded by left heart disease. So the patients that had the highest PA pressures, we found that 16 versus 11 actually had left-sided heart disease. Even looking at echo, we know that there's poor acoustic windows, and hyperinflation can cause difficult visualization of the TR jet to even estimate what a systolic PA pressure may be. And indeed, in echocardiography, in COPD patients, PA pressures are overestimated in 52% of cases. So should we right heart cath everybody? That's the gold standard for diagnosis, but we need to think about why we're right heart cathing people, and the use really should be restricted. The guidelines would promote right heart cath only in evaluation for lung transplantation. If patients do clinically worsen disproportionately to their ventilatory impairment, then we start to think about pump failure and should investigate it more. If gas exchange abnormalities are worsening disproportionate to what you see in ventilatory impairment, then again we have to consider what the heart's doing. If you need an accurate prognosis, the big one is inclusion into clinical trials and suspicion of left heart disease that's treatable for improvement of the patient's overall state. In terms of distinguishing COPD-related PH from pulmonary arterial hypertension, we know that COPD, being a common disease like obstructive sleep apnea, may coexist as a minor factor in PAH itself. PVR may increase maladaptively in COPD, so it's hard to pick out who's who. And exercise testing seems to be one of the best tools we have out there to distinguish the two entities. So again, in the guidelines that were set up at the last PH meeting in 2013, you see a few different strategies for picking out who might favor group 1 PH versus who might favor group 3. PFTs are important in COPD. High-res CT findings are important. In terms of exercise testing, we're looking for ventilatory predominant versus pump predominant findings. And we'll talk more about this in a little bit. In terms of treatment for PH-related COPD, obviously the big thing is your standard guideline-based therapy for COPD treatment. Smoking cessation, inhalers, pulmonary rehab, oxygen, all cornerstones of therapy. Long-term oxygen does prevent progressive increase in PA pressures if it's used for greater than 18 hours a day. There are recent studies that came out in the New England Journal of Medicine that may refute this for more mild hypoxemia. However, this study did not include or exclude patients based on hemodynamics, and we really don't know the effect on our PH patients. Despite treatment with oxygen, it appears that hypoxic vasoconstriction is not a fully reversible problem. When PA pressures are elevated due to COPD and patients are treated with oxygen, they don't really normalize. How do we treat them? We can talk about a few studies that have been done in terms of acute vasodilator therapy. This is trials with vasodilators over a very short period, maybe 40 to 72 hours. And what we know is that the acute use of nifedipine does decrease PA pressures and increase cardiac output in COPD patients. Unfortunately, these benefits appear to be outweighed by VQ mismatch due to the loss of hypoxic vasoconstriction. Losartan has also been studied in this same fashion with no improvement in systolic pulmonary pressures, exercise capacity, or symptoms. IV epoprostenol for severe PH in COPD has been used. As predicted, it decreased pulmonary vascular resistance, and as predicted, it decreased PaO2 levels. Inhaled iloprost has been tried and seemed to improve both 6-minute walk distance and PaO2 in an initial trial using a very low dose of the drug. However, in controlled trials using 2 treatment doses, double and 4 times the initial trial, those studies showed worsened VO2 and resting gas exchange. And in terms of sildenafil therapy, both 20 milligrams and 40 milligrams, as predicted, would improve pulmonary hemodynamics, but seem to worsen VQ mismatch. If oxygen truly is overrated, we can kind of put it out of our minds for a little bit and talk about some longer-term studies that have been done with oral therapy here. And a few of the studies I wanted to look at, the first one is a study of 30 patients without PH due to COPD. They're COPDers. They all had a systolic PA pressure of about 35 on average. They were treated with bosentan for 12 weeks, and the primary endpoint was a change in 6-minute walk distance. The study did not meet its endpoints. There was no change in 6-minute walk, systolic PA pressures, and those patients all had worsened oxygenation. But if we look a little bit further and look at patients that do have PH, hemodynamic data, right heart cath, mean PA pressures on average of 37. In the second trial of another 30 patients with COPD-related PH were treated with bosentan for 18 months. The treatment group exhibited improved hemodynamics, they had improved exercise tolerance, and they did not appear to have a detriment to their gas exchange over time. Looking at sildenafil, a trial of 10 patients, again without PH. These patients were actually excluded from the trial, received sildenafil or a placebo, and then crossover over a 4-week period. And the study looked at 6-minute walk distance as well as VO2 max. And again, there's no improvement in exercise tolerance. And these patients actually had a worsened quality of life. They felt terrible. But looking at 33 patients with PH, as defined by a systolic PA pressure on echo greater than 50, 20 milligrams of sildenafil 3 times a day was given to 33 patients fitting into this criteria. And again, looking at 6-minute walk distance, after 12 weeks of treatment, these people on average had an increased 6-minute walk distance of 191 meters. Pretty significant. In terms of the rest of the studies, combining either sildenafil or tadalafil with pulmonary rehab in severe COPD patients with a mean PA pressure, again, hemodynamic studies, less than 35 failed to show any outcomes in exercise tolerance. So it would seem that the mean PA pressure cutoff of 35 that was described in the guidelines for severe PH in COPD does appear to show the most promise in terms of benefit from vasodilator therapy. And we think that we might be looking at an altogether different patient, again with less airflow limitation, but with pump failure. The remaining questions that we have to answer at this point with several small trials is when does the pH itself become maladaptive and heart failure symptoms predominate? Because we know that lower PA pressures can either be indicative of less severe pH or worsening cardiac output, and we can't use the term out of proportion to describe these people. Again, exercise testing may help us out with this. Can these group of patients benefit from vasodilator therapy? Finding these patients is difficult. Performing large trials is even more so. And is the oxygen detriment that we're causing with pulmonary vasodilators truly an undesirable outcome if it's outweighed by hemodynamic benefit and overall delivery of oxygen? So in terms of the patient that I described to you previously, she was diuresed in the ICU to near euvolemia. She was started on IV treprostinil. Her BNP actually slowly normalized. and again, presenting in right heart failure, now has over 6 to 8 months an NYHA functional class of 1 to 2. She's been weaned off oxygen. We have added on a second agent, and she's in transplant work up here. This is, again, her old echo. Focusing on the right heart parameters, her TAPSE is very low. Her fractional area change, very low. PA pressures were 75, and she had a flat septum. Her most recent echo is a lot less wordy. Her RV function has improved quite a bit. Move on next to PH in interstitial lung disease. And again, another patient example that we have is a 25-year-old female, former social smoker. She was diagnosed with mixed connective tissue disease 4 years prior to presentation in our clinics. She now has connective tissue disease-related ILD, and has been on multiple courses of steroids, disease-modifying agents, and biologics. But she presents with worsening fatigue and dyspnea. However, her CT really hasn't changed that much. She's referred into our clinic for an abnormal echo. Her PFT and CT changes. Again, kind of what we'd expect to see in our connective tissue disease sort of patient type. It's a right heart cath on her. RA pressure was 1, mean PA pressure was 30. Her wedge was 8, her PVR was 4.2 Wood units, and she was not vasodilator responsive. This 25-year-old woman walked 180 meters. She had a relative desaturation, and she couldn't augment her blood pressure on exercise. Again, what do you do with her? So pulmonary hypertension can complicate any interstitial lung disease, but more so in the fibrotic types. We believe the incidence of ILD is increasing. It's likely due in part to increased surveillance for lung cancer screening. At present, 8% of patients with a greater than 10 pack year history will show evidence of ILD. The incidence of IPF itself is increasing for unknown reasons. We're up to about 94 new cases for every 100,000 Medicare patients. This is a chart showing pH prevalence in each of the ILDs. Note that pH occurs most often in idiopathic and immunologic forms of interstitial lung disease. But it's hard to find the true prevalence, again, based on very few studies and based on who we're looking at. There are reports of pulmonary hypertension anywhere from 10% to 86% of patients with IPF, and it depends on when you look at them in their disease state. Looking at NSIP patterns, chronic HP, you're looking at 36 to 50% in those patients. Based on the full population, the true prevalence is probably lower, but the patients that encounter medical care, this is what we're finding. If you look at very early IPF patients, those patients that have an FVC greater than 50%, that don't show a lot of honeycombing yet, that don't show any sorts of heart failure symptoms, PH appears to be present in about 15% of those patients. A third of that 15% will have a high wedge pressure with group 2 disease. Again, we're looking at a disease of generally older people in fibrotic lung disease. If we look at them at transplant evaluation, pH occurs in 35 to 45%, but if you look at the explanted lungs themselves, there's evidence in just about all of them. What we know about pulmonary hypertension and interstitial lung disease is that it is generally mild. Half the patients will have a mean PA pressure less than 25, and then you're looking at 25 to 35 being the other half here. But even mild pH early and late in disease is associated with a poor functional status and worsened hypoxemia. If you want to compare the 1-year mortality of IPF patients to those that have pH and those that don't, in the first year since diagnosis, a 28% mortality in pH versus 5% without. We'll talk about this graph a little bit more later, but it's oftentimes difficult to find the trajectory of any one patient's disease. They have two different problems, and they're their own moving targets. So trying to find out who has ventilatory failure and who has pump failure is what we're always trying to do in the PH clinic with these sorts of patients. And then we have to question, just like in PH, with a fibrotic pattern, is pulmonary hypertension due to just vascular ablation? Seemingly not, because there's heterogeneous patterns in different types of ILDs that all lead to pulmonary hypertension. There's really no correlation with the degree of restriction on PFT and PA pressures. In fact, patients who have an FVC that's greater than 70 seem to have worse pH, and there may be a survival bias to that. Do you have a question, Dr. Morris? I thought you. Okay. Gotcha. Perfect. So I just want to pull up a few pictures. You have kind of in clockwise format a UIP pattern, an NSIP pattern, a chronic HP pattern, and a COP pattern that you may expect differing levels of pulmonary hypertension based on what part of the lung may be ablated. Almost expecting that in a chronic HP pattern with a bronchovascular distribution that they may have higher PA pressures. But there's really no proof that central fibrosis along the bundle causes any greater degree of pH than any other pattern, whether it's UIP, NSIP, or COP. As you might predict, in terms of the inflammatory components of all of this, the usual inflammatory suspects like platelet-derived growth factor, TGF-beta, endothelin-1 are all upregulated in both PAH and IPF. So as the two diseases coexist, we look at the big picture. There is parenchymal and vascular damage from fibrosis. There's additional shear stress on the rest of the non-damaged lung. But there's also an inflammatory component with the cytokines that we talked about. There's a lot of comorbidities involved also. We know that sleep disordered breathing occurs in 90% of patients with IPF, and a vast majority of them will have an AHI greater than 15. Looking at nocturnal hypoxemia, these patients have to pull in a greater inspiratory effort. They get hypoxic at night. They have higher pressure swings when they breathe at night. Heart failure with preserved ejection fraction is comorbid in about 16% of patients that have IPF. And IPF patients have a propensity for thrombophilia. They have a high prevalence of antiphospholipid antibodies. Unfortunately, those patients were studied in the ACE trial, and they did worse when they were given Coumadin in the hospital. So in terms of testing for pH in ILD, we do have some clues. We can look to the PFT, and we know that the diffusion capacity is probably the single best marker in pH. Patients with a DLCO less than 40% predicted are 10 times more likely to have pH. Restriction really doesn't correlate, as we talked about before. The 6-minute walk test is useful, and you can almost look to separate out patients with pH because you know they'll walk less and they'll desaturate more. If we look at 6-minute walk tests of patients with pH and without pH, what you find is, again, in IPF, the patients with pH walked about an average of 143 meters. They desaturated to 80% on average, versus patients without pH walking 365 meters and only desaturating to 88%. Small study, only 34 patients, but still some good data. We don't look for this on our 6-minute walk test, but looking at 1-minute heart rate recovery, if patients don't recover their heart rate by more than 13 beats per minute, that is also suggestive of pump failure. And again, if you are going to hemodynamically test these patients, either with an echocardiogram or right heart cath, you have to pay attention to left-sided comorbid states. Again, heart failure with preserved ejection fraction, 16% of IPF patients. It's a disease of older patients, and they do encounter a lot of comorbidities. Can we treat it? Again, as you predict from what we talked about in COPD, the use of vasodilators is limited to case series with mixed results. Routine treatment of PH and ILD can't be recommended by guidelines at this point, and patients should be referred for clinical trials if they're available, preferably under the care of an expert center. And again, the best thing we can do for our patients is support their primary disease and deal with any sort of contributing factors, including sleep disorder, breathing, or left heart failure. So looking at some of the studies we do have available, the ERAs were initially promising because of their antifibrotic effects, and they have all been studied in IPF. Both Bosentan with the BUILD 3 trial, Maxitentan with the MUSIC trial, and Ambrisentan as a subgroup of the Artemis IPF trial all show lack of benefit in the typical endpoints that we look for in PH. Drugs in the nitric oxide pathway have mixed results. Looking at the STEP IPF trial, patients were randomized to sildenafil 20 milligrams TID versus placebo for 12 weeks, and then an open label crossover. These were pretty sick patients. They had a DL less than 30%, which should suggest a high pH population. It failed to meet its primary endpoint, which was a 20% increase in walk distance. There were small improvements in DLCO, oxygenation, and quality of life, surprisingly. There was a non-specific, although trending towards that, improvement in mortality with treatment. But most importantly, if you perform a subgroup analysis on patients that we did have hemodynamic data for, looking at the patients with RV dysfunction, there was a significant increase in 6-minute walk distance with sildenafil treatment. Take it a step further and look at riociguat. The RISE IAP trial was done, including patients with idiopathic interstitial pneumonias, but was terminated early over safety concerns, so not completed. And then looking at prostacyclins, a small open-label trial of IV treprostinil was done in 15 patients with IPF and severe PH. Again, mean PA pressure is greater than 35. It did show significant improvement in hemodynamics and their functional metrics. RA pressure decreased from 9.5 to 6. Mean PA pressure decreased 47 down to 39. And the 6-minute walk distance did improve quite significantly, 171 to 230, without a significant drop in O2 sats. So the questions we're left with ILD are, who are the right patients to treat? Again, every patient has two diseases and they're their own moving targets. As they progress along a plane of ventilatory failure, do they have an adaptive or maladaptive pattern to that failure? And when do we find them in pump failure that can be treated? So finding the right patients is difficult. Improvement favors patients with higher PA pressures and RV dysfunction. And should we be treating these patients as a bridge to transplant? In terms of studying these two diseases concomitantly, what are the best endpoints to look for? We know that 6-minute walk distance is affected by both ILD and PH. And it's difficult to associate these changes to any single disease process. And the time to clinical worsening may be the best option to look for in this complex disease set. In terms of ongoing trials that we have, we are performing or recruiting patients for one trial here. The INCREASE trial is looking at inhaled treprostinil in subjects with pulmonary hypertension due to parenchymal lung disease. The thought being that delivering drugs specifically to better ventilated areas of the lung might lead to less VQ mismatching and overall better exercise performance. So we're looking at patients with PH due to any interstitial idiopathic disease, chronic HP, occupational or environmental lung disease, and combined pulmonary fibrosis and emphysema. It is a hemodynamic driven sort of trial. We're looking for patients with mean PA pressures greater than 30, and we're looking at the change in 6-minute walk distance over 16 weeks. Going back to our patient that we found in the clinic, to help better with decision making, she underwent cardiopulmonary exercise testing. Her VO2 max was 40% of predicted, which is about 12 cc's per kilogram per minute. She didn't really increase her tidal volume much, but her respiratory rate went up to 47, although she did not exhaust her respiratory reserve. We did note that her end-tidal CO2 did decrease, seemingly due to ventilatory inefficiency, and her pulse ox stayed, or I'm sorry, her O2 pulse stayed low. So looking at the typical graphs that we're used to seeing, her O2 pulse on the left in blue, below what's predicted, and you can see in the in these lines here, that drop off in her end-tidal CO2 that we have linked to pulmonary hypertension. So with her results being more indicative of pump failure, she was started on dual oral therapy, as well as ongoing immunosuppression. Under the AMBITION protocol, she was started on ambrisentan and tadalafil. And this is her repeat 6-minute walk distance. She increased her walk by 105 meters. She had no desaturation. She had no hypotension. Her echo actually normalized over time, and her BNP went down to 10. So the last disease process I want to talk about combines the two. And you don't get a cartoon for this one because no one had a sick enough sense of humor to make fun of it. But looking at both IPF and COPD leading to PH, we know that IPF is associated with a variety of comorbidities, and obviously COPD is so prevalent that there are patients out there that combine the two. It is a relatively new term, though. It was described as a unique syndrome in 2005 in a hospital in Britain, and in initially 8 patients, all with this cryptogenic fibrosing alveolitis with emphysema. The same study group went on to look at 61 more patients and describe them further. They all had upper lobe emphysema. They had lower lobe fibrosis, most of them with a radiographic UIP pattern. They had a high prevalence of PH, and they had severe dyspnea with normal or subnormal FEV1 to FVC ratios, but they had a markedly decreased DLCO. We know that it's a tobacco-related phenomenon, and there's a history of tobacco abuse in about 98% of these patients. They have a mean pack year usage of about 40, and there's a higher prevalence of emphysema and IPF in Europe than in the US it's reported. So I told you about 8%. But in Europe, we think that due to higher smoking rates, it may exist in about 21 to 33% of IPF patients there. And again, in a 9-to-1 male to female ratio. This goes back to 40 years ago, more males than females smoked. If you look at the patients who have connective tissue disease and they smoke, it gets even worse. Patients with RA have emphysema if they've ever smoked, about half of them in any RA-ILD. Emphysema in about 48% of ever smokers. Existent systemic sclerosis and just about everything else. Polymyositis, Sjogren's, mixed connective tissue disease, interstitial pneumonia with autoimmune features not otherwise specified, chronic HP, and sarcoid. And the precapillary pH, again, as we talked about with the inflammatory component, may go back to this tobacco-induced inflammation. As you'd predict, lung cancer is a more frequent complication than in your standard IPF patient. What we're looking for in terms of diagnostic clues with these patients is DLCO severely decreased with a pseudo-normalized spirometry. And looking at a whole set of patients, what they found was relatively preserved lung volumes with absent or moderate obstruction. These patients had an FVC of about 90% predicted, FEV1 80%, a ratio of about 89. Total lung capacity was still up at 88%, and DLCO was 37. They desaturate much worse on a 6-minute walk test, generally by about 9%, up to 15%. They do get hypercapnic, but late in the disease. In terms of imaging, this is going to be where the money's at for diagnosis because there's so many different factors in the equation. So high-res CT is crucial for diagnosis, and especially if people have such bad emphysema, you may not want to pursue a surgical lung biopsy. You want to look for the typical patterns in UIP. Look at honeycombing, reticulation, traction bronchiectasis, and abnormal architecture. Ground glass may be present in a non-UIP pattern, but in a vast minority of the patients. Emphysema is going to be present in all patients. It's usually a centrolobular or paraseptal. Panlobular emphysema is rarely found. And just as a few examples, several cuts from a patient who is a male smoker. You can see the emphysema up top in a centrolobular pattern, and then going all the way down into your typical UIP pattern. And looking at kind of a similar pattern, this is another gentleman who is a smoker with predominantly paraseptal emphysema and a UIP pattern. The clinical course is interesting. It's generally patients who have emphysema first, with PH occurring about 18 months after the diagnosis of concurrent IPF in emphysema. So you can see that whole track record of patients having clinically significant emphysema for about 5 years, presenting later with fibrosis, and then PH. They give you the 12 months there because we have well-studied patients with mortality data at 1 year. It's a poor prognostic sign. You can see the patients who have PH in the dotted lines there, as opposed to the patients that don't. And even at about 1 year, drops off. We do have hemodynamic description of a cohort of 40 of these patients. Looking here, again, mostly male. We talked about a 9-to-1 distribution. In this particular study, 95% of them were male. They're about 68 years old, smoked about 46 pack. years. They had a 6-minute walk distance of 244 meters. They desaturated to an average of 77%. Their mean PA pressures were 40. Their wedge pressure was 10. None of these patients had a wedge pressure above 13. Cardiac index was 2.5. Their vascular resistance was 521, and their SVO2 was 65. The overall survival for these patients with PH was about 60% at 1 year, so 40% mortality in the first year is quite significant. The things that predicted death in these patients was low cardiac index and high PVR. So just again points to the importance of pH concomitant in these diseases. The deaths were mostly due to hypoxemia. In terms of looking at the disease once it's diagnosed, there's really no guideline consensus for echo surveillance, although expert opinion does suggest annual screening once it's isolated. We would consider the same indications for right heart cath as in other group 3 disease. Again, evaluation for lung transplant is probably the biggest one. Inclusion into clinical trials and suspicion of any sort of left-sided heart disease contributing. And again, using the same picture to figure out who has group 1 predominant versus group 3 predominant disease. We talked about this, and it's more applicable in COPD because you have to wonder about any of the sorts of PFT abnormalities if there's a combined obstruction restriction, if there's pseudonormalization of these issues. High-res CT, again, kind of questionable because you have multiple disease processes present. Really where the money's at is with exercise testing to pick out who has pump failure and who has ventilatory failure, or at least what's predominant. In terms of treatment of the disease, again, general guideline-based care aimed at the treatment of emphysema and IPF are recommended. So everything's on the table. The available studies that we have are small. They can't really support any use for most patients with COPD or ILD. And then COPD and ILD, again, even fewer studies. Exercise testing may identify patients who could benefit from treatment as a bridge to transplant. Where are we going with the disease? Inclusion of CPFE itself historically was not done in looking at either COPD-related PH or ILD. However, it is strongly encouraged to be included in future trials. In terms of treating these patients with ERAs, that is discouraged based on what we talked about in terms of anti-fibrotic effects of the ERAs on the diseases previously studied. The RISE IAP study, again, we talked about, was studying riociguat and symptomatic PH and terminated due to safety concerns. I will note that our INCREASE trial does include CPF patients who meet hemodynamic criteria and demonstrate midterm stability in their O2 needs.
Brian, is there any talk of looking at Sildenafil or that class again? Because I feel like that STEP IPF study really set things back because one of their exclusion criteria was that they had a right heart cath that showed significant pH. So they selected out patients that had pH, but they just didn't have a right heart cath.
And even in the subgroup who did have RV failure, despite what we saw in the PA pressures, there was benefit.
And they didn't report huge drops in oxygenation. And
Right.
There did seem to be some symptomatic benefit. Do you guys know if there's any talk of looking at that again? I know they kind of shot themselves in the foot.
There's a lot of interest from industry in looking at non-group 1 patients. And unfortunately, the design of most of the trials isn't specific enough, I think, to really aggregate the very, very small number of patients who are likely to benefit. But that is something they're continuing to try to refine.